Good evening. I'm Mark Santos. I'm the president of ION's GPO. I want to thank everyone here tonight, our industry partners, our practices, that took time to come away and spend this evening with us. We felt it was our imperative as the market leader to lead the charge in this program. But I must also thank Lilly and Eisai, especially tonight's program for Eisai, for supporting, being the pillars behind this program so that we can educate the community, get you involved. First slide I'm going to show you is what has ION done, what have we done as your partners, and what can we do going forward. The going forward is the more important message. You'll hear from Barry shortly after this about the value of community. Here in the video, access, patient care, quality, cost effective, all very important messages. Barry has the data now. We can prove that that happens in the community. It's important that we all get on the same message. Saving community oncology is our imperative. Well, what have we done? This is an event here, structured a little bit different. We have a lot more industry representation, but thank you also for our practices that are here represented. Media coverage, the big splash that came with sequestration. A lot of that we managed to, through our firm, start the noise. Our practices got involved. Dr. Boccia, Dr. Pacerka, others made national news. And outreach, letters, phone calls, and even what's upcoming, kiosks that will be available for your practices. Some of the stats to date, 3,600 visitors to community counts. Individuals have sent letters, practices. This is the important part. We can make a lot of noise. We've made a lot of noise without you getting involved, without pharma being more partnered with us in a congruent message, without you getting your patients involved, your staff involved. We're running out of steam. We need you. We're not going to stop. We're going to continue to push, but we need you. To come, based on some recommendations from our advisory panel, they asked, could we help you, walk you through this as a practice? So we have kiosks that our oncology supply now will be shipped to you with content you can hand to your patient. How do you get in touch with your representative? How do you get in touch with your congressman? Those sorts of things. What is actually happening in education in this space? So all things we're trying to support you, but we need you. And when I say you, I mean industry and I mean practices. We're committed. If any of you have picked up the USB drive tonight, if you're not, I ask you to, because Chris, Barry, others have done a lot of work. There's white papers explaining the value. There's value presentations, actually slide decks you can use with your payers. Actually present the data to them. This is how do you reach out to legislators? How do you become an advocate? Rita and Mitch are going to be up a little bit later to talk about what they see from going on in Washington. And patient education. Getting patients involved is absolutely critical. So I thank you for coming, and we'll have a good program for you tonight. First, you'll hear from Barry. As I said, he's going to present the data on the value of community oncology. You get a Washington perspective from Mitch, from our Representative Elmer's office, and Rita Norton, our own, from our legislative staff in DC. You'll have a panel, physicians, pharma, myself up here, answering some questions that Barry has prepared, but also please engage, ask us the questions you want to know about. And we're going to close with, how do we have a united message going forward? Byran's actually going to speak from an industry perspective. Lilly was very instrumental. Byran came to us and said, we want to be involved as Lilly. We believe this is important. We need the message. We need community oncology for innovation, for investment, for going forward. So with that, I'll turn it over to Barry Fortner, the president of ION Solutions. The great Dr. Fortner will supersede me in speaking, I will tell you. Thanks, Barry.
Kent was my best friend in junior high. And for about 6 months, every day, I wrote down every homework assignment that he had. We were competitive and we were both fastidious about academics. And so each day in great detail, I wrote down every assignment, and by phone or by snail mail, I mailed those assignments to him. See, in 1982, in rural West Kentucky, When you got cancer, it meant that the whole county threw a fundraiser and that family went away. That was cancer treatment in 1982 in Benton, Kentucky, in Mayfield, Kentucky, in Murray, Kentucky. Flash forward to my next most personal experience. I was a doctoral student, and I had been working with the West Clinic for a couple years and had learned about coping with cancer. And my mom's best friend, I had heard through the years about the diagnoses and had heard about the recurrences and the trips to Texas for prolonged treatments, but now was hearing that there was a change. And so I was going to go talk to her. It was still her eyes, but her body was noticeably different. And as I made my pitch, she didn't hesitate. She looked at me and she said, "Barry, I'm not going anywhere. I want to talk about where we're going to eat tonight and where we're going next week and what decisions you're making in your life with your young family." She said, "I'm not going anywhere." She wanted her treatment in Pulaski, Tennessee. And that's where she got it. You see, over the past 20 years, there is a beautiful story, an amazing story of scientific innovation, the creation of a robust portfolio in which we have gone from a handful of drugs applied broadly across a complex and multifaceted disease to a point now where we have FDA-approved regimens for virtually every major disease category and line of therapy, and now beginning to encroach on tighter and tighter indications into niche areas. But the untold story of the last 20 years is that during that same time period, because we have created antiemetic medications and other supportive care regimens, and we have tightened our schedules and the way we deliver these drugs, we've been able to take care from restrictive urban academic centers to hospital centers to then contiguous outpatient centers to hospitals to freestanding autonomous community-based clinics, and that has allowed us to take a complicated, toxic, very serious anti-neoplastic treatment approach and make it available literally in every nook and cranny in the country. It is a beautiful story of access. But it turns out that community oncology, even more than simply being the predominant way that chemotherapy is delivered to cancer patients in America, it turns out that it has the best value proposition. Little did we know in 2003 when we were discussing changing the way drugs were paid for and the invectives that were being levied at physicians to support those political changes. The innuendos that have been continually levied at physicians through this time period, that all along, it turns out that not only were they behaving well, not only were they maintaining high standards of quality, but it turns out they were delivering a care that compared to the alternatives delivers a significant cost effectiveness equation. Even 2 years ago, talking about this would have gotten a rebuttal from the audience. But now we've seen so many internal studies that it's become almost mundane to talk about community oncology as the lowest cost side of care. And in fact, now, not only industry-based studies demonstrating this, but we're beginning to even see some recognition that there are wrong-headed, even irrational policies by Medicare that instead of facilitating care in the lowest cost setting, that there are policies and behaviors that are actually, ironically, doing the reverse. You see, it turns out that community oncology is vitally important to delivering cancer care in a healthy way in the United States. It is part of the equation that has created a system that is the envy of all the world. And tonight, with our two panels, I would like for this group to consider the depth of that importance across the entire continuum of care. You see, we have been on a campaign these last 18 months, and this is now our 8th city to hold a major event. And we've been calling our physicians and administrators to action, to take up the data, to begin to pound out the message. But tonight, we're also calling on our closest industry partners, the folks within whom we are in a symbiotic relationship, in which we are interdependent, to take up the call, the story that suggests that community oncology is a critical part of our argument for innovation, for patient access, for quality. Just to stop on that for a second, it's completely impossible to talk about healthcare reform and to talk about future ratios of quality if you begin by restricting points of access. You simply can't restrict access and have an overall better quality equation. And so when we begin to talk about shrinkage, the closing of practices, the reduction of satellites, the folding in, the consolidation of regional delivery systems in cancer care, there's no way to make that fall on the positive side of the quality ledger. And as we put up the drug releases over the last year, for many in this audience, I would have you think about the way the current portfolio has been born. That many of the slides we use and some of the great work being done by folks in this audience to tell the innovation story, I would politely ask you to consider that many of those slides that emphasize the clinical trial process, the scientific process, even the cyclical feedback loop in which we learn by putting a drug in the market, that whole system runs because it has a market in which to work. The formula that has been successful over the last 20 years has been amazing scientific innovation within the context of a strong economy with a free market into which to give birth to those drugs. You see, we're contemplating a market in which Dr. Boccia, who will be on the stage in just a moment, in which him looking his patient in the eye, him having to answer in good conscience to that patient in 3 weeks when he sees them again, him having to make a decision about the way that patient is going to live their life, and seeing his nurses every day, that is no longer the deciding factor about what regimen, what drug, what supportive care agent is used. We're looking at the potential of a system in which that decision is made by a host of different intermediaries with disparate business models, potentially conflicting business models, that intervene into that process. You see, we would like to make the case tonight that having an autonomous, independent, community-based oncology market is critical to our continuing the war on cancer for the next generation of drugs that we bring to market. Now, there are significant threats, no surprise to folks in this audience today, and we won't go into detail except that they be discussed a little later, but these threats are real. They have caused a shift in the marketplace beginning in 2005 to the present, and they are unrelenting. But I would tell you that we remain undaunted. We absolutely believe that the fundamentals associated with the community-based physician will eventually manifest themselves, and the promise of many of the zeitgeists of the day over time will begin to show some of the aspects of those models which are fallacious. Instead, we would call our physicians to continue to innovate, continue to be efficient and lean in the way they practice. We see We deliver your drugs to every point of access, and the fact is that your drugs cannot be inventoried and managed in that inventory any way comparable to that being done by the local oncologist. The cost effectiveness and the benefit to the patient, to the payer, to you, even to the government, is uncomparable in any other situation. And we would urge our oncologists to lead in quality discussions. Instead of it being dictated to us, we need the community-based oncologists and practitioners to begin to have a voice that actually is defining that debate. We need to continue studies. Though we've established the fact that they're the lowest cost side of care, and though we have refuted many of the false accusations against the profession, the fact is we need to continue to lay down studies that further enumerate the value proposition of these practices. And this year, you're going to hear from us in the Community Counts campaign that we need to engage our oncologists in a way that activates them politically with a unified message like never before. That needs to happen with the physicians and with their administrators and with their patients, but it also needs to happen in a unified way with the professional societies that represent them, and of course, as I've already pointed out, with many of our friends here in the room today with our pharmaceutical partners. So I will end. We'll begin our main events with a very simple call to action. Thank you for coming tonight if you're coming from a practice. We know the difficulty of getting to these events, and we know the importance of giving your patients every ounce of energy and attention, and we appreciate the work you do, but we are challenging you and your peers. And you're going to hear a challenge from ION this year. As a group, we need all 1,650 of our practices and the other practices outside of our sphere. We need all of them to educate themselves on the data that's available to support your business model. We need you to begin to carefully and appropriately, with the highest level of ethics, to engage your patients. They are the ones who have the most to lose in this battle. And we believe that patients are going to have to be engaged if we're to have an influence. Communicating with representatives, your local and state and national representatives like never before. Conducting practice tours, holding town halls, and attending and hosting political fundraisers in a way that community oncologists have not traditionally, things that community oncologists have not traditionally participated in. And to pharma, I would close by asking you to consider the community oncology argument in your lobbying plans. That you begin to tell a story that also supports directly and indirectly the message of the need for everyone's benefit that the community continue to exist. And that you collaborate, even persuade the professional societies and other industry organizations to cooperate together and come behind this unified message. And of course, our campaign has been successful in raising attention and awareness, and we believe there are powerful opportunities for you to even join with us in supporting this effort. So again, I thank you for being here, and I appreciate everyone's dedication to the field, and we'll now move on to our next panel. Thank you. Rita Norton, who will lead our discussion. Rita is the head of our regulatory affairs. Many of you do the same for your companies, and so you know her well. And I would just say that Rita has been really amazing in our company. She's established our presence in Washington, D.C. She built our department. She has a long-standing successful record across the industry. And for those of you who are in practice, I would tell you that in personal knowledge and discussions, I can say that Rita wakes up every day thinking about what she can do to further your causes. So Rita, I'll allow you to introduce your guest.
Thanks, Barry. Thanks, everybody. And I think Barry's messages are so important. I have actually been working on these issues for longer than I'd like to say. I was involved actually when I was at Amgen in the when the legislation on the Medicare Modernization Act passed in 2003, and we never foresaw some of the problems we're having to live with now with the reimbursement methodology that we're trying to get corrected. And I just like to say, I don't know how to explain to you how lucky we are to have members of Congress who are really fighting for us in trying to correct some of these issues, trying to keep community oncology alive and correct some of these reimbursement problems. So I've been doing this a long time. As Barry says, unity has been a huge issue from day one. The cancer community is united behind patients, but unfortunately we've got a lot of diversity in the messaging and different elements of the community. So we've got to continue to work, try and find ways to work together and fight for the same thing. And Steve McMillan here from Eisai, I've been working with him for many years. Sean Donahue from Lilly, and we'll all be up here later to talk, but we've all been on this battle for a long time, so I want you to know how committed we are to this. I'm really happy to introduce Mitch Vacrex from Congresswoman Renee Elmer's office from North Carolina. She's a nurse. She's in her second term. She's got tremendous energy, and if any of you haven't met her or seen her in action, I can't believe how much energy this congressperson brings to this issue. She's learned it to the nth detail. Of course, being a medical professional, we're so fortunate to have medical professionals who understand cancer and the treatment of patients and how important this site of care is. So Mitch is her legislative counsel. He's worked for this now over a year, I think almost 2 years now, working hard on trying to find a solution to not only some of the reimbursement problems, but sequestration, which has compounded it all. So Mitch, can you tell the folks about what legislative counsel to Congressman Elmer is and your background a little bit?
Sure. So as legislative counsel, I do have a law degree, so sorry I have a cold, but we do discuss judicial and legal issues. We have the attorney-client privilege. We can have confidential conversations, but I'm doing all healthcare now, all the time. And like Rita said, we've been working on this particular issue since April last year.
And so Mitch has been on the Hill. He helped the Congresswoman start her Washington office, and she has been tireless. She introduced legislation to exempt Medicare Part B drugs from sequestration, and she is, I think daily probably, Mitch, talks to the leadership about trying to find a way to get this fixed.
So, and we've been talking about this. We do have a lot of momentum for her bill right now, and it's HR 1416. It's called the Cancer Patient Protection Act. And she is, to Rita's point, she is very fierce, and she knows what she wants, and she's not afraid to go up to leadership, to go up to committee chairman and say, where are you with my bill? I've got 109 co-sponsors. We've had a legislative hearing on it, and this is real. I mean, she knows it's real. We know that cancer centers are actually really closing, and that patients aren't getting the care that they need. So she's very conscious of it, and yet we're fighting daily, yes.
And I think last week in the hearing, she actually questioned MedPAC and said, why are we having these issues? Everybody knows it's more cost effective to treat these patients in the clinic, and they're being sent to the hospital. Why is this disconnected?
Right, so MedPAC was there on, I think, SGR extenders. So we went off topic though, because when we learned about the physician fee schedule cuts and how they're going to cut the communities, the oncology centers, but actually increase the hospital setting, she got angry, and it makes no sense. It makes absolutely no sense. So she did use that opportunity to question MedPAC on it. And we do have MedPAC on record saying that it doesn't make sense, and it's one of their proposals to have site neutrality. And the head of MedPAC did at that point on the record commit to communicating with my boss on this issue and making sure that CMS listens, because it seems like they're frustrated too.
So Mitch, we want to give these folks an idea of there's hope here. I mean, with members like Congressman Elmers, Congressman Whitfield, Senator Stabenow, others are fighting so hard to try and get something done. The environment is very difficult, and Sean and Steve can attest to this here in Washington, to get things fixed. How can we give them hope that we can get something done?
So there is hope, and there's a lot of momentum here. So we do have 109 co-sponsors, and we do have momentum with the SGR package, and it's a good fit. So that's our strategy now, is to get HR 1416 into the SGR package, which we know is a must pass. They have to do something, whether it's a replace and repeal or a 9-month patch, whatever it is, that's a must pass. So that is our strategy right now, to make sure that 1416 is included. And to what Barry was saying, it's essential, it's absolutely essential that you all are doing your part in reaching out to your member and your senator. My boss, we typically, a lot of members won't get on any bill unless they hear from their constituents. It's incredibly important. I can't emphasize it enough. It doesn't matter if a company comes in, a group comes in, unless we hear from our constituents, we are not going to get on a bill. So please, I mean, Barry's absolutely right. Call your representative, call your senator. I don't know the ethics behind talking to your patients, but yes, get them to do it. Their constituents too. Tell your friends, tell your neighbors. I mean, the more co-sponsors we have, the better chance we have of this becoming law.
Thanks a lot, Mitch. I really appreciate it. I mean, I mean, the power of grassroots is what's needed here, and it's not volume. It's the quality of the story, right? The specific. I'm a patient. I had to go to the hospital. My copay's gone up, or I can't get a ride to the hospital. Those are the kind of stories they need to hear.
No, exactly. I mean, and that's the thing. It is real, and practices are really closing. So, and the reports are, Barry spoke of the reports, and those are very helpful too. And I'm constantly sending those to leadership. I'm sending them to the chairman, making sure that they know that this isn't just a story in the Washington Post. There's actually real people behind this. It's really happening. So yeah, we have to have the data.
So you all know Mitch now. He'll give you his email and number. You know, Congressman Melbourne is extremely accessible, as are our other champions in Congress. And or as you know, we have the website, makes it really easy to access who your legislators are. And you know, I'm just going to echo what you said. We've got to keep this grassroots, you know, make this. It's hard to find time in your day to do these things, to reach out, but they need to hear from you. And we've got a really critical time period coming up here. They're trying to get something done here in the next month or two, right, Mitch?
Right. So I mean, something has to be done by the end of March. Is that right? The end of March. So. And right, everything is. If you're looking at a total repeal and replace, which I'm sure most of the folks here would be for, it does get complicated when you have Boccia. Senator Boccia is going to go be ambassador to China, and he said he wants everything done. He said he wants everything done before he takes that role, and that's happening early February. So if it wasn't short enough, let's just go ahead and make it shorter to fit his timeline. It's a real crunch. So yeah, time is not on our side.
Now is the time.
Now is the time to make the call if you're ever going to reach out and to your senator or representative. Now is the time, absolutely.
And can I just also add one more thing? The power of positive is really important here. I mean, it's right now everybody's angry, mad, frustrated, but I think thanking, there's please know how many legislators are trying to help right now. Thanking those like Senate Congresswoman Elmers, working with Mitch, giving lots of time and energy to this is really important, and we can help with that. So please join me in thanking Mitch for joining us.
All right, the panel can take the stage. So let me introduce our panel. First of all, here to stage left is Steve McMillan. Steve, thank you for coming. Steve is the Director of Federal Policy for Eisai since 2008, and he is the current lead of the Washington office. He's got extensive experience in the biopharmaceutical industry across multiple companies and over 11 years of legislative oversight experience in the House of Representatives in 1981 and 1993. So it's fantastic. Thank you.
My pleasure.
Let me introduce Byran next. Byran Litton is a known quantity to most folks, and certainly within Lilly, but it is, I think, just a fascinating role that he's playing right now, really for all of you in the pharmaceutical industry. He's the Senior Director of Payer and Advocacy and Professional Relations at Lilly, and is heading a unique project called Patient Access and Cancer Care Excellence Initiative in the U.S. Environment, and he's focused on shaping and preserving the value of incremental innovation. He's really showing leadership in that area amongst the industry. Prior to this, Byran, again, most of you know him, has been in significant leadership positions across the company, and Byran, thank you for coming. So say introduced Rita. So I'll move to the others and say a word about Mark, who you know is the president of the GPOs. I will tell you something you may not know about him. First of all, he is a pharmacist. So he's not just a pretty face. He's that. Pretty Cajun, but he's also the real deal. He knows his stuff on drugs. And maybe more importantly to our discussion, he comes out of a real practice. And before he joined ION a number of years ago and really helped found our company and grow it, he was in a real practice, managing real patients and a real pharmacy spend and a real pharmacy inventory. And so he just has a lot of assets, and thank you for being on the panel.
Thank you.
Finally, Dr. Boccia. Dr. Boccia is not one on introductions, but I usually torture him anyway. He's the founder and medical director of Center for Cancer and Blood Disorders in Bethesda, Maryland. He's also a clinical associate professor of medicine at Georgetown University. Importantly to us, he is our medical director for ION. And I would tell you, in leading our advisory board and dealing with many of you around contracts, but beyond that, he really is the quintessential community oncologist. And the way he treats patients, his expertise, there are some folks in this room who have called on him late at night because we have personal issues that we want his knowledge on. And he really is what we want in a community oncologist, in both his willingness to live his life around patients and yet that acute intelligence with the research and his deep clinical knowledge. So thank you, Dr. Boccia. I'm going to ask a question to each of the panelists. While I'm doing that, you be thinking of your own questions. I will open it up to the audience after this first volley. Byran, I'm going to start with you, okay? That's all right. Out of the gate. This issue of community oncology's role in the whole industry's well-being, does the pharmaceutical industry recognize that? How do you see that? Lilly and the industry as a whole, and what does it mean that community oncology could be under threat?
Well, so I get the question. I get the question when I do practice about what do you think on Lilly's or against this? And I do think we talk about integrating some of the community conversation into external enthusiasm. I think that over the past couple of years, I think a lot of people would believe that we're okay to find a molecule, manufacture it through the distribution channels, and then we're okay with where the drug is administered. That's not the case. And there's some reasons for that. I think the first reason is that having choice inside of care, which is how we phrase it when we have that conversation, is important for patients. You told the story well, and I don't have to retell that, but I grew up in West Virginia. And it's not the easiest thing to get out of a holler to get to Charleston or Morgantown. And so having care that's accessible and close is important. That's practical. That's practical for my immediate family in West Virginia today. The other piece of that is, it's not a small thing. If you take a look at the video from the Litton, you're able to pull up to a facility like that and get treatment there. It's a very good proposition for pulling up to So first of all, it's right for patients, and we do talk about that, we think about that. And so I think that leads, and then for us, there are other practical reasons. As the expense is what it is in the hospital setting, when things are expensive, that rolls downhill on the industry. We should bear the scrutiny on our price for sure. For the cost of the explosion of the cost of healthcare in the U.S., when it's more expensive, that brings pressure downhill on us. When people land in the hospitals, they land in 340B institutions, and that is not really feeling anybody. And then the last piece that we see is that physicians lose the time when they go to the hospital setting often. Again, for those of us in the industry, we want to be able to have physician have the time to do the decision making. Those for us are three really practical reasons why we don't want to understand. And that's why we support the community hospital.
Stephen, again, just assuming that you agree that the community dominating this market is a good thing for pharma, how do we translate some of the areas of residence into actual work together, into actual lobbying efforts or messaging efforts? How do we make that real?
I think that a lot of folks in this town are on the same page. I think on the basic level, when you're at pharma and bio, and we're talking about these issues, we're commenting on the rules, we're looking at issues that are coming before Congress, we're always talking about access to the full range of treatment options, that patients should have the ability to go what is best, where it is best for them to receive the most effective care. I think part of the message, you're right, is there is a perception about us as an industry that we can talk that and they're like, yeah, you just industry. Or you can talk about doctors and they'll find some bad story and say, well, gee whiz, that's all the doctor. We just have to keep hammering home the same message. And we can't just focus here in DC. One of the things you're talking about is have people write, have people contact. Well, Congress is back in home vast majority of the time. Their recesses are well advertised. I think it's incumbent upon people, and we talk about people in our company, we let them know, Congressman so-and-so is going to be in your district. They're on recess. Go to a town hall meeting. Invite them if you're in a practice, no matter what size. We know you happen to be in town. Next week, you're going to be in the district. Come over here and listen to us, learn from us. Even those of us who work in the field, my previous employer, we owned a healthcare delivery system. And I finally got a chance to go up and watch them deliver cancer care for 5 days and go to the pharmacy, go to the imaging. That's a learning experience. And people in town here think they understand it at a certain level, and they don't. They don't have a clue. The best thing is they're on the ground knowing that the member of Congress, House Representative, Senator is in town. Bring them over to the practice and show them. Tell them. And also find out, you know, the family members have cancer as well. They are the best advocates. You know, it's like, if you don't believe me, I'm sure you have a cousin somewhere. I'm sure you have an aunt and uncle who's had to go through. Ask them what it means to them. You know, put it on that personal level so it resonates beyond just what is the policy here, what's the budget number we're trying to hit, what's the thing we have to protect the leadership, and make it personal.
So somehow, actually, the community may actually be able to provide the pharmaceutical industry with a tether to actual patients and to people and to real stories for us to make this message of the importance of the innovation cycle as well as cancer care be more impactful.
Absolutely, yeah.
Mark, a lot of people don't realize how closely aligned we are with community. In fact, I've taken people, as you know, down to Dothan for shock value because when they go in and they see the way that distribution machine works at such a efficient and accurate level at a very, very small margin, it really changes their view of the infrastructure that's been required to create community oncology. But what about ION's position, its relationship with community oncologists, and what we can do to try to empower them?
Well, for one, being totally selfish, and Barry and Dave and others from ION Oncology Supply will be totally selfish. It is the only place that we do business from ION and Oncology Supply. Now, AmerisourceBergen does business across the spectrum. But we believe from the ground up, meaning from the physician office, from you making autonomous decisions, you bringing innovative products to market, is how patients should be treated. And that's what we support, and we'll continue to support. We've done, I think, a good effort, mostly through Barry's work and so many others in the room, of bringing us, McKesson, USO, COA, ASCO. So from a community standpoint, we've got a lot of coalescence. Why we're here tonight, and I want to thank Lilly and I want to thank Eisai for supporting, is asking other members of industry to come along on that message. We need to all be together. Anytime we can be fractured on the hill with disparate messages, we're weak. So a way to bring that together. So this is the next part of the evolution, much as we're asking the practices to do more, get involved. What we're going to ask industry is to align better with us, align better with the practices on a unified message.
Rita, I'm going to skip you, okay? And be thinking of your question, and I'm going to ask Dr. Boccia to kind of give his view of this. I mean, Dr. Boccia, you know, sometimes it seems like the community oncologists, they have no friends, to be honest with you, when you're in Washington. There are a lot of powerful organizations. There are a lot of powerful trade groups. And yet, there are friends. And I think the question is, how do we get industries that are truly aligned with the community to coalesce into a more powerful force? But I think for you, I'd like for you to also comment about your peers. How do we activate them? There are 5,000 community oncologists who in some way touch ION. How do we make them real, literally? If they did something, every representative and every senator in the country would be touched by their activity. Your thoughts?
What you say is absolutely true in the sense that we don't start off with friends on the hill. You have to make friends on the hill. So we've seen as legislation has been passed over the years, healthcare legislation, that they don't consider us as part of that process. They consider patients, they mainly consider the budget as part of the process. So the first thing is that we need to better make friends on the hill. Second is that we are constituents, but we're only a minority of those constituents. And unfortunately, until you make friends, everything you say sounds self-serving. So that's an issue that you have to get over. And one of the ways that you get over that is to begin to engage some of the other constituents that you have direct contact with. And there are two basic groups. One is your patients, which is the biggest group of constituents, and the one group that legislators over time have always listened to most. Because they know that they're not only constituents, but they really are people in need, that they're there to serve, and their committees are there to organize efforts to help. So it's critical that those people become involved. And the other group that's in there is your staff. Your staff are constituents. They're not viewed as self-serving with any significant degree like doctors are. So I think that's one of the ways that we can better do that. As Rita was saying, you know, you don't want to go there with a chip on your shoulder. You want to go there. And so the practices in general have to figure out how to do that. The doctors have to get their heads out of the sand. And I'll just give you an example. I've been to a couple of these. I was out in California for one, and we had a room of 45 people, and many of them were physicians. Unfortunately, if you look across the room tonight, we have some great administrators, but we don't have a lot of doctors here, right? So the big question is, why not? Which is the question you're asking. And I think that some of them just are overwhelmed. Some of them are overwhelmed enough that they don't know where to start. Now, ION has done an amazing job of trying to teach them, but as they say, you can bring a horse to water. And so what we hope from some of these meetings is that we will give clinicians the tools to go back to their practices, because they won't survive if they don't. I mean, I would ask those here from practices to think about how your life has changed with sequestration, how your life has changed with the repeated SGR fixes, and when you didn't know for the last 12 hours whether it was going to get fixed or not. What you think now of the new physician fee schedule, and what's happening in your community with regard to survival. And that's from the hospital competition to the basic reimbursement small business model that we all practice under. So, I mean, those physicians need to wake up. Those physicians need to get engaged. Those physicians need to engage their patients, they need to engage their staff, and they need to be proactive in order to survive. Or none of us really will. I think, Barry, you mentioned, I mean, we have the Millman report. We have, I don't think you quoted numbers, but maybe you did and I just missed it. I think it's 300, roughly almost 300 groups have gone into the hospital in the last several years. 300 of our, we're just talking about oncologists. We're not talking about practices in general. It's much more overwhelming than that. And somewhere over close to 500 clinics have actually closed down. So this is real. This is real.
Let me open it up first to practices. We have a couple practice representatives. Anybody have anything that's been said resonate with you that you want to underscore or question, perhaps, from somebody in the audience that's from a practice? I heard a compelling story in the lobby dealing with the day-to-day pressure of managing a drug inventory. I thought was fantastic. Any comment? I would love for you to.
Well, we're always very disappointed and frustrated with all this. It's very hard on us. Everything I figure out, I always have to remember, and we're not really making $10 on this drug when you get to take out the 2%. So it just seems like everybody's always hitting you in the head, even though on the fee schedule I say, hey, something is going up. So, no, it costs more to buy or something. So we just never get it. It's very frustrating. I don't know what's going on.
One of the things you said, if you'll beg my pardon in sharing our conversation, was that you now have to approve and review every order every day. You can't let one slip by.
The doctor just was telling me I better go look for another job this morning because, I mean, he gets frustrated too because the physician, you want to treat this person. Oh my God, this person didn't found this lump and for 6 months she hasn't done anything and now she's presenting and I want to get her started this afternoon. Well, when you talk to the patient, she can't afford the 20%. If you try to get the pharmacy benefits, maybe she does, maybe she doesn't, but she can't afford those benefits either. Then it's like, well, let's send the patient to the hospital, and then you're up against that because even though you're sending them out, but then you're sending them out. The doctor's still writing that order and taking care and being responsible for that patient, but you're not getting paid for it. So it's.
You told a dramatic story of sending a patient out to try as a last resort to brown bag. They saw the copay and came back to you and asked to be sent to the hospital.
And I think it's so unfair with this 340B and the hospital, getting more money for treating the indigent patients, and we're just losing every day.
So, what does the panel think about this administrator's plight? By the way, the physician telling her that she's going to have to get a job might have been her husband, so that's a statement. I mean, Byron, think about that. Every order has to be reviewed. There's no room for error.
Yeah, I think one of the challenges that we need to take a look at, especially as we're going to be in the heart, even beyond sequestration, is even as we come into the heart of payment reform, this is not the next fight, it's the fight that we're in currently, and we need to be in one place with that fight in around payment reform, is the payment reform needs to recognize the work that goes into delivering care to patients. And much of what we're seeing, whether it's bundling or episode of care or any one of the number of schemas that we're seeing in payment reform, do not reflect the opportunity for that. In fact, I think it would put us in a community setting in a more difficult situation, many of these payment models. If you push risks down to a lower level, people are going to try to demonstrate. So I think even as we're fighting this fight to preserve community oncology, part of that is looking out ahead and being able to have a proactive voice in shaping what payment reform will look like. From our end, from industry's end, I think there's a couple of things that we can do, and I'll be cautious here. I'll speak to the decisions, as my team has pricing responsibility, I'll speak to the decisions that we've made in the past. I'm not portraying what we'll be doing in the future, as I can't do that. But when 340B has grown, it hits us not only in deep discounts with an increasing portion of our business, but 340B patients are exempted from the calculation in and around ASP. And so what that does is it magnifies the discounts, small discounts that we provide to the GPOs and suppresses our ASP. And then sequestration came in and further suppressed ASP. So for those of us who are in a long time model of taking incremental price, starting out at a low price, taking incremental price increases, we turned around and we had a decision to make. And at that point in time, it was a point for us to stand with some solidarity with the GPOs. And we had two tenets that we set within my group. We wanted to make sure that we maintained our ability to contract with the GPOs. That's been good for us, and we think it's been good for the GPOs over time. That was important. And the second piece, we wanted to do that up to the extent that we would not put community practices underwater, whether they were contracted within a GPO or not. So for us, speaking not just for industry, but individually, those were two conversations that we had because we know you're facing that, particularly in the heart of sequestration. Did we do that exactly right? I'm not 100% sure, but I will tell you as we walk through that decision process, our relationship with the GPOs and not putting people underwater were awfully important to us.
Byron, I just want to just make mention of something that you talked about earlier and tell you a little bit about what we're doing, and that is when you talk about payment support. I think everyone in the room, when you saw the video, understands that the healthcare system is always changing, that quality measures will be introduced, and the payment system as we knew it is going to go away. But we've also been told that if we don't do it ourselves, the government will do it for us. And so we've heard originally from ASCO, who had come up with a model, and understanding, at least from the community perspective, that ASCO doesn't represent us in the same way we would like them to represent us. They really started off as an academic institute, an academic membership, and remain much like an academic membership and think like academics do rather than, I hate to say it, but business people, we own small businesses, but to understand how to operate them. So we have joined and have now you might call it a committee, but represented by ION, US Oncology, COA, and ASCO. We are looking to present to the legislation a payment model that they can work with and that we can still maintain viable practice under. So that's actually ongoing right now. And so there are other activities that are going on that you may not be hearing about, which are important. So a lot of people out there doing a lot of different things to try to help us all. We just ask that you help us in the way that you can, which is to do, like I said, mobilize your forces, your patients, your staff, yourselves. One of the most powerful things that I hear about as I talk to people across the country is Stephen was saying, is getting people into the practice to actually look to see how you do things. Those that haven't visited our legislators really don't know what goes on. They don't see people with bald heads sitting in the infusion rooms with little emesis basins next to them. So those are powerful ways to get to people. If you have the chance to do that, that's a great thing. So if you find out that perhaps your representatives haven't done that, that's a good way to introduce them to the trials and tribulations of your practice.
The hardest part we've got here is that everybody's transient, certainly on the staff level. There's just not a lot of knowledge. We're great that we have more and more doctors and healthcare professionals who are in Congress that we can talk to and they get it on a basic level. But unless you as a patient or a caregiver for a patient has sat in the office and had the conversation exactly like you're talking about, or gone into a pharmacy to have them figure out what they've ordered, what they've got, how they're going to ship something in, you don't have a lot of people here in Washington, and I don't know what it's like on the state capitol level, that understand that have been through that realize that it is a fine line. So a lot of what we do here in DC is education, but a lot of what has to be done out in the countryside is that education. 300, 500 practices closed, 300 merged with a hospital. The immediate reaction of staff's like, oh, well, I went on a tour of that hospital, and that's a great hospital. Like, I have a beautiful lobby, great artwork, and it's great, they're doing good work. But they don't understand what it means with the patient sitting in the chair, how much time that patient needs. When you think about oncology, and I was talking to our people who were involved with our antiemetics, and I didn't even really think about this either, but how important antiemetics are. Because if that patient gets sick right there, well, that means a whole cascade of things happens in that room that makes things even worse for the practice. A simple thing like that. I guarantee you people up on the Hill don't understand that. They just think, well, the patient got sick. What's the big deal? It is a big deal. And they don't know it.
So let me open it up to the rest of the audience. We actually have a lot of experts in the audience tonight from the pharmaceutical industry. What about this case we've been making tonight about the importance of community oncology? Is there room for us to have more of a coalition around supporting these issues? Any thoughts from anybody? Any thoughts? Doug, I'm calling you Dave. Sorry.
Thanks very much. First off, compliments to the panel and for the thoughtful comments that have been made so far. What's clear to me is that the messages or the arguments have been well crafted, and I think it really shows. And Eisai has been involved with the community accounts program plus or minus a year now, and I think as we start thinking about payers, because certainly payers are important stakeholders in this whole conversation, when to approach payers becomes at least as important as what it is that is said to them. And if you understand how the benefit year flows, now is the time. We're just after the open enrollment period. Health plans and PBMs are starting to think about what it is they want to do for benefit year 15 and 16. So getting these messages into their hands, providing them with the ammunition, the understanding that the cost of community care, the quality of community care is best in class are very important messages to get out, particularly if you're looking to shape the landscape of 2014 and beyond. So I think one of the takeaways that we ought to have is that whether it's through doctors working through their health plan representatives in conversations around whether you're in or out of a network, or conversations with health plan payment groups around, do they understand what the cost of care is or is not? Those things, now is the time to have those conversations, because when it comes down to September, October, November, December, it's too late. That benefit year is closed. They'll look at it, sell in, and then enroll patients, and the whole cycle starts again in the early part of a calendar year. So I would encourage us to take away from this meeting the opportunity that we need to be out there now if payers are going to be a part of this process.
Panel, this is an interesting point because Dr. Boccia's relationship with payers is very granular. It's very local, and it's usually very tight around what contract they're offering, and sometimes it's rather hostile. Your relationship with payers is a little higher, is it not? This is an interesting point. There may be a missing part of our campaign to payers that these messages needs to be included in, and it may be that our relationship with you can embrace that. I think that's fascinating.
I think the interesting thing about that dynamic with the payer, I think the newcomers of the world at United, the Michael Cologés of Aetna, and other folks who are often out engaged in the discussion of what's happening in the environment, a lot around payment reform, those folks are aware of the differential in the cost and the side of care. So I think that awareness level is already there. I think it wouldn't take a great deal to move them to some action in and around that. As they've openly said, we get it, we understand it, we believe Albury Norman. And so I think you have a group there that's cost conscious, obviously, and aware. We just haven't seen action in and around that yet.
They actually have a couple of pilot programs right now. So
actually, at a very grassroots level, that's actually starting to take place. It's pretty amazing to your point that United Healthcare, with its size, muscle, and bottom line, that they can't do something in a little bigger way, understanding. I mean, they presented to us at an ION meeting 3 years ago, when UPMC took over Allegheny County, that they lost in the subsequent year with the same patient population and the same doctors, $200 million. Just his plan. And now we have our first grassroots. It's shocking.
Just to push this just a touch, but you know, the pharmaceutical industry makes decisions about limited networks for their drugs. There's also a relationship with the PBMs. There are negotiations with payers. And you know, sometimes the physicians end up kind of on an afterthought of the way those drug plans and the way the strategy is formed there. Humbly, I would tell you, we think that's an opportunity for us to begin to kind of change the way things are heading. Any thoughts on that, Steve?
Well, I defer to my business colleagues on that level, but I would say that, again, on the DC, on the advocacy side, I think you find good alignment with where we are with the physician community and what they want to do. Now, you're always going to differ on strategies and tactics at certain points because that's just the way Washington is. But I think that the unifying message that we've always put out, and I brought out one of these cards just to make sure people know it, you know, our motto is HHC, human health care. It is really, literally an important part of us as a company. And we convey that when we go to talk to the Hill. So we're talking about, yes, we're involved in the business, but our main focus is patients. They have to have access to the full range of treatment options. Patients are different. Patients respond to treatments differently. Doctors have to have the ability on site to say, you know what, I need to give you this, but I need to give you that, and I need to give you that. They have to have that freedom to do that, to be able to really practice medicine and get the outcomes. And I think that aligns greatly with the message that that your care, you know, the physicians around the country want to do. But you know, you have to then. And it's kind of curious, before I forget, the notion of a pilot. All right, and it's a personal bias in mine. There are pilots all the time. We've got PCORI, the Patient Center Outcome Research Institute, with ACA. They said, we're going to do pilots on this and pilots on that. I was wondering, what happens to the pilots? They may come up with some great information. How is that information conveyed, both upwards to the decision makers to say, hey, we found something that really works, but also among the practices themselves on, you know, that this is something that's going to save your practice in Nebraska, your practice in West Virginia. How does that information get out?
I think it's only going to get out if it really hits them in the pocket.
Right.
So that's it.
Yeah. So you may have good information, but how is it conveyed? It may benefit West Virginia, but if they're not hearing it in Green River, Wyoming.
Well, you know, it has to start and work its way up to the plan, and the plans are members of the larger national plans, so that's the one way to work.
So we're short on time, but as we begin to close up, I want to introduce just one new topic, but it's something that's been talked about tonight. I just want to underscore. Rita, we've been really polite with patients, and anytime they get mentioned on the Hill, sometimes there's a little backlash that it's not fair to involve patients. You mentioned it a little bit, others have mentioned it a little bit. That's missing largely in this cancer equation right now. There is no strong grassroots presence of the patient's voice. Is that something realistically that we can bring into this effort?
Well, I hope so. I mean, as some of you might recall, right after sequestration, there was a lot of media attention brought to patients are going to be turned away, patients may lose access. Those numbers really caught legislators' attention, which was important because we're fighting among a lot of different groups trying to get Congress's attention on patient issues right now. But then the patients, you know, were not heard from because the doctors took care of them, got them to the hospitals, and a lot of the patients didn't really know what happened. And we missed that. We missed an opportunity there, and it kind of made the story look a little, is this really true? So I think we need to think about that. We need to focus on that, because the members of Congress need to hear from patients. They've heard from us, they've heard from manufacturers, they've heard from doctors, but a few patient stories is what can really move them and make them come to action and realize something has to be done. So anything you can do to help us find those patients and get their voices, their stories told, it's going to be critical.
Any other comments on this?
Oh, I agree, and a lot of the members of Congress and their families, they've been patients. They don't like to talk about it sometimes, but that resonates with them. They've got family members with them. So.
Well, one of the things you will hear from us is we're about to distribute, for example, patient kiosks so that physicians' offices will have a convenient way to distribute literature to their patients in their lobbies. And we also want to talk to you guys about other, even grander ideas, because frankly, we're not sure that the community oncologist brand is clearly defined in the marketplace. That patients actually know the difference between an oncologist who's practicing on one side of the street and the employed oncologist who's practicing on the other side of the street. And so we're not so sure that there's not a public level of understanding that together we don't need to bring about very quickly. Mark, I'm going to let you have a strong close. What, hearing this, and you've got a lot of great pharma partners in the room that you've dealt with on many issues.
We're going to be much more bold in our ask this year from our pharma partners and also our practices. We've tried to do a lot of background work, but you've heard repeatedly from people that sit on the Hill, we're about spent. They've heard our message. It now comes from you. Now, our pharma partners are going to ask how we can wrap around much tighter, create a unified message from our practices. You need to be much more involved. It can't just be Ralph. It just can't be the Nebraska guys making a video and talking. Everyone needs to be involved here.
Yeah, Mark, I'm going to tag on, not to be the last word, but from my seat to the industry partners in the room, we know what it costs to stand up a campaign, and it's expensive.
Mm-hmm.
And so I think we're at a point in time with the community where they're asking, are you going to stand with us? And there's something that Jackie Jordan, our colleague, found at Lilly when we entered into this, is that as word got out in the halls of Lilly, there was a sense of pride. They understood very well that there was separation in this activity and our commercialization activities. But there was a sense of pride because they're out, many of them are out there. They see this day in and day out, and that we were making the right decision staying with them. That was collateral upside that I didn't necessarily expect. But we certainly had that. And our people are asking us what's next. I get that question almost on a weekly basis. What's that relationship going to look like moving forward? So I think it's a time for us to stand in partnership. And the story of delivering innovation, we have the same story.
Mm-hmm.
So there's so much synergy there. So not to step on a good solid close, but for me this is an emotional thing. And I think it's a good time for us to get to action on our side of the fence as well.
Thank you for that. Listen, thank you for coming. Appreciate everybody's evening. And again, we're here because we believe in helping cancer patients get the best absolute treatment, regardless of their socioeconomic status, regardless of their geography, and because we believe in the community oncologists and many of your work. So thank you for being here, and good night.